All right, and welcome to Elbows positioning number 9. What I first want to let you know is make sure you take the patient's clothing off. Um, Buttons and seams and things of that nature can show up on the x-ray because there is not a lot of other things here. And radiologists really need to see some very complicated processes with the fat tissue and fat pads and the bones. So that being said, be sure to make your patient take off their shirt. Now, the elbow is not fun. In fact, it sucks. The proper positioning for an elbow, or the proper projections, we have an AP, two obliques, and a lateral. Um, what we do for the AP is I have a patient sit in the chair. Here's a table bucky or bed or whatever I'm doing it on, and the whole arm needs to be in alignment as best as you can. Okay, so I'm going to turn this way so that you can see. And this is what they're talking about the interepicondylar line. All right, on your humerus, right here, you have two epicondyles. You have the medial epicondyle and the lateral. No, medial epicondyle and the lateral epicondyle. So when I make it flat, you can feel those two bony projections right there, and that is flat. When I go 45 degrees outside, and when I go 45 degrees inside. Okay, we're making those obliques to be at 45 degrees, which is exactly half of a 90, right? So you need to have the entire plane parallel to the image receptor, all of these bones. You're going to center your central ray just directly into the middle of the elbow there, okay? Include some of the proximal radius and ulna and the proximal humerus. And that is your AP elbow. So, like I was saying, for this one's the easier one, the medial oblique. You're just going to turn everything just a little bit inwards. This one gets the coronoid process in profile so that you can see it. Again, include from about here to here and shoot central. Now, this next one is the lateral oblique, and it's the hardest one to do. Sometimes I'll even show my patients what to do. I'll help hold them back, or I'll help put a sandbag there and just say, hey, you can help hold on to this. Because essentially what you're going to do is roll out the entire arm. And I want you to try this on yourself to see actually how hard it is to do. The hand needs to go with it, okay, because that turns those bones together. So when you see the epicondylar line, boop, there you go. So that's about your 45, right? And you can feel that. That hurts your arm to do. You're going to shoot again in the center of your elbow, and this is going to open up your radial head, radius being your thumb side. You can see the radial head right there in profile. So, that hurts. Let's do the lateral. Now, the lateral is just like the forearm. It is the most important one that you have to get at a 90-degree angle. And remember, if you look at your IR and you look at the bone placement of where your arm is, you can line up your bones with the edges of your IR. And you go, okay, that's a 90 degree. You have to have all of it on the same plane. Get your shoulder down and get the hand thumb up. Don't let the hand rotate because that crosses over the bones. So thumb up, and we're going to have it at a 90-degree angle. And we're going to shoot right here in the middle. And this one is the most important because this is how you're going to see those fat pads. We have the anterior fat pad, which is on this side, the posterior fat pad, which is on this side, and there's also a supinator stripe, which is over here on this side. So this is the number one view that a radiologist wants to see when they're doing the elbow. Now, an elbow is very painful to do, and there's a lot of patients who may have elbow injuries. But that's not to say that you can't shoot it cross table. That's not to say that you can't shoot it on their chest on a bed. Remember the two-part plate alignment. I may have to hold it up and shoot it like this, in order to get a lateral elbow. Wherever they can do it, that's what you do. And let's say, for instance, you have a patient who cannot fully extend their arm. Maybe it's broken. And they come to you like this, and you have to do an elbow. So what are you going to do for that? Well, we have two projections that we can do in order to visualize an elbow. And this is going to require a little bit of movement. You're going to have to move them around, raise up the table, put the table down, get a different chair, however you need to do it. Because it's best to explain it to the patient and say, hey, this is what I need you to do. Just bring your arm, place it as flat on there as you can. And they go, okay. So you're going to shoot it just like that. All right. This is a proximal elbow. All right. You're shooting these bones in a flat plane in alignment with the image receptor. So then what? Well, you put a chair behind them and they're not able to move or bend their arm. And you say, okay, I want your arm all the way flat like this. Have them see if they can move their fingers out of the way, because then you're going to come in and you're going to shoot a proximal humerus. All right. You're essentially shooting that joint in two different ways so that the radiologist can look at that joint. And in two different pictures. So this is a proximal humerus. I'll let you look at that. The central ray would come in right about here and shoot this part. And this is a proximal elbow. Okay. So there are other projections too that we can do for a trauma elbow. Sometimes it's just a matter of doing the best you can with what you have. But say a person comes in and this is the way their elbow comes, and they cannot extend their arm. So what I'm going to do is I'm just going to be like, okay, set it down there, and we will shoot it like that. And say one of them I want, this is where the central ray is going to turn like this, and I'm going to shoot it this way, and I'm going to shoot it this way, because you're taking a picture of this bone and this bone superimposed over each other so that the radiologist can look at whatever's going on in the elbow. And then you can also still do a lateral. And that may show you where there is a break, there is, an avulsed injury or something of that nature. It may be the only way that you can get a lateral elbow, but you're also going to put in notes saying patient trauma, lateral in situ or whatever. So that is, just remember, please don't extend someone's arm against their will and or wishes. I coax a patient and be like, hey, do the best you can. I'll help hold your fingers. If it's injured, it's injured. We're not going to just sit here and make them put it down, because that's going to cause more injury. I find a lot of techs want to try and do that, but that is not okay with me. And I want people to be as gentle as possible to not cause further injury. So that is your elbow positioning.